Looks like everything is getting started, so we'll go ahead and begin. Welcome. This is a cost report training that we are putting on for the CCBHC, or Certified Community Behavioral Health Clinics, in the state of Indiana. This presentation is being provided by myself out of the Division of Mental Health and Addiction, with accompaniment by our contractor and very, very helpful staff of Tim from Myers and Stauffer. Going to allow Tim to introduce himself.
Yes, hello. My name is Tim Durant. I'm a partner with Myers and Stauffer, and as already mentioned, we've been engaged by the FSSA Division of Mental Health and Addiction in the Office of Medicaid Policy and Planning to assist with the cost report and PPS rate setting aspects of the CCBHC program. And so we're excited to be part of the project and look forward to presenting on today's training.
Thank you so much, Tim. As Tim mentioned, they will be assisting us in the state of Indiana as we go through this cost reporting process with the CCBHCs. Myers and Stauffer has an extensive amount of experience in this field with other states, so we're very excited to have them assisting us. So thank you so much, Tim, and your team. As we go through this presentation, we will be first and foremost reviewing a few things. So next slide, and also to introduce a couple other folks that are here. We have Nick Burt from ICASO Consulting, as well as Mariah Alexander from ICASO Consulting. And ICASO has been incredibly helpful for organizing and managing this large initiative that we have. So thank you to the ICASO team as well. This presentation is going to be a recording, and we will be publishing it on the DMHA website. As it is a recording, there will be no questions presented or answered during this presentation. All the questions that you may or may not have, please submit those to the CCBHC questions at fssa.in.gov email address that is presented here. Questions will be published in the form of a questions and answers document that will be published on the DMHA website. Please be sure to use a subject line of cost report training when you pose those questions, so we can monitor which ones are directly meant for questions about the cost report training, and so we can answer them as quickly as possible. And then DMHA and OMPP may conduct stakeholder listening sessions as well to answer any questions in a live forum, should we feel that we need to do so as we review the questions. So just wanted to make those quick statements about the presentation as we prepare to begin. The next thing that we'll review are the objectives for today's presentation. First and foremost, we will have an overview of the CCBHC program and model, as well as the prospective payment system and the rate, the PPS rate, and how it plays into the model itself. From there will be a review of the cost report submission items that are required in order to prepare the cost report, as well as an overview of the CCBHC cost report and the reporting process. And now we'll do an overview of the CCBHC model. So CCBHC, as I am willing to bet the vast majority of folks listening to this webinar have an understanding of what CCBHC is. CCBHCs are certified community behavioral health clinics. They've been established as a demonstration program through CMS since 2014. But in Indiana, we have been moving towards the development of CCBHC in Indiana, but most importantly, in 2022, during the legislative session, we got Senate Enrolled Act 1 across the legislative session, and it became our Senate Enrolled Act that really solidified that CCBHC would be the statewide transformation of our current behavioral health system. This locked in that we are going to be moving towards this and making this a prime initiative at DMHA. What CCBHCs have really done across the nation and the CMS demonstration is change the way that behavioral health services are paid for to provide a comprehensive range of mental health and substance use services. The CCBHC model has been proven as an outpatient model that ensures access to integrated services, including 24/7 crisis response and medication-assisted treatment. And that access and insurance of access and expansion of it is something that we really felt fit the needs of Indiana and our behavioral health system. The CCBHC model ensures that strict criteria is met regarding access, quality reporting, staffing, and coordination of social services, justice, and education systems. We felt that this strict criteria would be a fantastic way to bolster the quality of services that are provided, as well as expand them in a way that really meets the needs that we have been seeing across our state. And then finally, the CCBHC model receives funding to support the real cost of expanding services to fully meet the need for care in the communities through a prospective payment system, which is a rate that we'll describe throughout this presentation. So regarding access, and that being a key tenet of the CCBHC model, anyone who requests care for mental health or substance use, regardless of their ability to pay, their place of residence, or their age, including those that are developmentally appropriate care for children and youth, they should be able to receive services from a CCBHC and should have services provided if they come to a CCBHC requesting such services or in need of such services. And there are 9 core services that every CCBHC must provide. Those core services are crisis services, screening, diagnosis, and risk assessment, psychiatric rehabilitation services, outpatient primary care screening and monitoring, targeted case management, peer and family support and counselor services, community-based mental health care for veterans, person and family-centered treatment planning, and outpatient mental health and substance use services. All of these services must be able to be provided by a CCBHC to anyone, regardless of their ability to pay, place of residence, or et cetera, that they need it. An additional point that I'd like to reiterate to all those that are looking through these services again is to remember that when it comes to the care coordination agreements that are possible in the CCBHC, there is that formal care coordination agreement called a DCO, or Designated Collaborating Organization. And DCOs can provide these services, these core services, up to 49% of the 8 core services excluding crisis. And that work that they do and those costs that are associated can be included in that PPS rate. So that's something I'd just like to reiterate as we review those core services. Now, putting the community in CCBHC. This slide really describes the overall process of how that PPS rate is developed for a CCBHC. And where it all really starts is that criteria, that strict criteria. The CCBHC criteria was recently updated in 2023. And with those updates, there were the ability for the state to make some changes. So the state of Indiana has made changes and published them through a process. And that's really the first step of all of this, of putting the community in CCBHC and development of a CCBHC model, is the state defining the CCBHC criteria itself. From there, the CCBHCs then develop a community needs assessment. That community needs assessment really looks at what the needs are of a designated service area, of the population within that area, and the kind of services and gaps and opportunities that need to be addressed as they develop their CCBHC. So the CCBHC then uses that community needs assessment to develop a plan for implementation and providing these services to everyone that they're anticipating and projecting they will need to provide services to. The CCBHC submits their community needs assessment and proposed implementation plans to the state for review. And then the CCBHC builds a PPS rate from their approved plan based on their implementation plan in their cost report template. So everything from the staffing to the different activities that are required to provide these services to the data needs, all of these different things are discussed in the plan, are approved by DMHA, and then that PPS rate is then built once all of that has been approved in order to support the costs of providing those services as described. And then the community needs assessment, as well as the CCBHC cost reports, are updated and approved by the state every 3 years thereon after. So then the next slide will really discuss what's the difference between our current state today in 2023 as we are and where we're moving with CCBHC. So the primary difference between our financial model for our current state and our future state is our current state is really a service reimbursement model where behavioral health providers and substance use treatment providers bill and receive reimbursements per service from a fee-for-service model. Now, there is a drastic difference where under CCBHC, that PPS rate is really a fixed reimbursement model, where all of the costs, including care coordination, administration, staff, data needs, all care for patients, regardless of the number of visits or insurance status, are factored into a fixed clinic-specific rate that is based on an encounter frequency. And in our case, that will be daily. So there will be a daily rate factoring in all of those costs into a fixed rate. So this is really covering the costs versus covering a fee for the service. Now, overall, as I said, there's that single bundled payment rate for each qualifying patient visit for all covered services and supplies. Now, this rate, known as PPS1 for the daily rate, is derived by first and foremost identifying all the total allowable costs, including the anticipated budgeted costs, the directed costs and allocated overhead, and then dividing that by the total amount of CCBHC visits that are anticipated. And then that gives the overall CCBHC rate. Now, each CCBHC will have their own unique payment rate based on their development of their cost report, which again predicates from their community needs assessment and staffing plan and proposed plan for how they're going to provide services and their CCBHC services in their designated service area. Now, for all of those rates, they're developed through a cost report process. That process is something that will be standard for all of them, where the state here first and foremost is providing trainings in an accompaniment with our wonderful friends from Myers and Stauffer. And then these trainings will be on the cost report template. And then the state will pose initial questions to prospective CCBHCs. We will request documentation as well as request submission of initial cost reports. The state will then review these cost reports in accompaniment with our contractors of Myers and Stauffer. And then we will ask questions, receive answers from the prospective CCBHCs, and then have final discussions that are needed in order to determine the final points for the development of that PPS rate. Once those final discussions have finished, then the state and Myers and Stauffer and all of us will get together and finalize those PPS rates for each unique CCBHC. So that is the overall process. And now I'm going to hand over the presentation to my wonderful friend, Tim Grant. Tim.
Thanks very much, Ari. So we'll dive into the cost report schedules in just a little bit, but we do have a few slides before we get there by way of a little bit of background information. And I may cover some of the information that Ari has already gone through, but I'll go through these pretty quickly. So many of you are already familiar with this information, but this slide here contains a brief recap of the federal legislative authorities supporting the CCBHC demonstration program. So it was the Protecting Access to Medicare Act of 2014 that was the original legislation that authorized the CCBHC program and established the criteria and standards, which in many ways still exist today. And a number of states, including Indiana, participated in initial one-year planning grants, and then 8 states were allowed to participate in those original demonstration programs. And so while Indiana was not selected for the demonstration at that time, as already noted, Indiana is planning to submit a demonstration application in 2024 under the expansion of the CCBHC program authorized under the 2022 Bipartisan Safer Communities Act. So that legislation expands the CCBHC program and allows additional states to participate. This slide captures, again, the 9 core services. So we've already talked about that a little bit already. But again, the CCBHC program requires the provision of 9 core services, and these must be provided by the CCBHC provider or through an arrangement with a designated collaborating organization, a DCO. And so through a combination of the CCBHC itself or through a DCO arrangement, the 9 core services must be provided. And so where this ties into the cost report from a cost reporting perspective, the cost report must include all of the costs associated with providing these services, whether they are the costs of the CCBHC itself or the costs that the CCBHC incurs when the DCO provides the services. So we wanted to include this as a reference and a reminder that these are the services that we're talking about when we get into the detailed conversations about costs. As already mentioned, at this time, the state has selected the PPS-1 rate. So this is the daily PPS rate for all services to a patient on a single day, regardless of the number of individual discrete services. So the cost report is designed to collect that cost and visit information and calculate the rate. And then the rate can also be trended from the cost reporting period to implementation, which is what the state intends to do, by using the cost report instructions on the MEI worksheet, and we'll get to that when we get to that schedule. Essentially a midpoint to midpoint calculation from the midpoint of the cost year of the provider to the midpoint of the rate year using the prescribed Medicare Economic Index, or MEI. And then there's also the possibility of a quality bonus payment in the CCBHC demonstration, and states have the flexibility to decide whether to implement a quality payment. And so just wanted to mention that that is a potential part of a CCBHC program, but it's outside of the scope really of the cost report, because the cost report data is typically not used directly in determining any quality bonus payment amount. The cost report is used to establish the PPS-1 rate. Next slide. You can advance the slide, Nick.
Are you all seeing the new slide?
I'm still seeing it on the PPS rate elements slide. Not advancing.
Apologies. One moment.
There we go. Thank you. So this slide is a schematic of the PPS-1 rate, and this was also shown in one of the previous slides. But so just to recap this quickly, the rate includes direct costs that come from the trial balance schedule of the cost report. It also includes indirect costs from the indirect schedule of the cost report. And those two items together comprise total CCBHC costs, and that is then divided by the number of daily visits to determine the PPS rate. That amount is then multiplied by the MEI inflationary index. And so one point I'll make here, and I may touch on this a little bit later as well, so the cost report collects total costs, and total daily visits for all of the 9 core services for all patients. It's not payer specific. It's not dependent on the patient's insurance status. So providers do not need to attempt to isolate Medicaid costs or Medicaid visit. It is total costs and total visits to determine the daily rate. For reimbursement, however, that rate is only paid under the CCBHC demonstration for Medicaid individuals. It's not paid out for patients covered under any other insurance or the uninsured. So in this next section, we'll go through some of the cost report submission items before getting into the cost report itself. So what to know for submission. So DMHA and OMPP will be providing a list of procedure codes. That's one of the most important things I think that providers will be interested in before starting to complete the cost report. This list will outline the codes that constitute a visit or an encounter for CCBHC purposes. It will also include the procedure codes that are allowable services but may not trigger an encounter or a PPS rate payment. So providers will use this list as the starting point for identifying the services that the CCBHC is currently performing, as well as any anticipated services that aren't currently being performed but will be performed on the demonstration that will need to be captured in anticipated costs and anticipated visits. So again, this list we anticipate the list will include not only the encounter triggering codes, but also the allowable services that may not necessarily constitute a face-to-face encounter with a patient. So an example of this might be care coordination services. So these would be activities that are necessary and included in the CCBHC service delivery, but they may not be captured by an encounter procedure code, but nonetheless, the costs are allowable and can be included on the cost report. The second thing to know for submission is we're asking that cost reports be completed based on the provider's most recent completed annual fiscal period. So for example, if the provider has a June 30 fiscal year end, the cost report should be completed for the annual fiscal year period, July 1, 2022 to June 30, 2023. If you have any questions about the cost reporting period, please reach out and ask before completing the cost report. So if you're trying to decide what cost reporting period to use and you just want to talk through what's the best period based on your operations and the timing of your fiscal year, we're happy to answer any questions there before you start, because we don't want you to complete a cost report and then change to a different time period and have to redo it. And then lastly, each clinic will submit a clinic-specific cost report to establish a clinic-specific rate. If you're a CCBHC with multiple service locations to provide all of the services, you can submit one cost report. But if you operate multiple separate CCBHCs, each CCBHC will need to submit a cost report on its own. So this slide contains some of the items that we're requesting be submitted with the cost report. And this goes into a little bit more detail than may would have been listed in the RFS or responses to the questions. It's really the same information for the most part. It just goes into a little bit more detail about some of the specific items we'd like to see. These will help you complete the cost report, and they will also help when the cost reports are reviewed to ensure costs are allowable and appropriate for the CCBHC program. So I'll go through these very quickly, and we'll talk about each one of them in a little more detail when we get to the cost report schedules. But the first item is the trial balance. So this is one of the most important source documents that contains the costs being reported. Most providers should be familiar with this document, as most accounting systems maintain a trial balance or working trial balance of expense accounts. The second item would be a crosswalk from the trial balance to the cost report lines. And this is helpful for the provider when the cost report is completed to be able to trace the trial balance costs to the cost report lines and also assist during the cost report review. We'd also like to see a depreciation schedule to be able to validate any depreciation expense being reported for equipment, for example. We're looking also to see for some type of detail report, claims detail preferably, to confirm how the daily visit count was determined. And again, this is to confirm, or this is to support a daily visit count, not a count of individual services. In terms of indirect costs, the federal indirect rate if applicable, because the cost report does rely on the federal indirect rate for indirect costs for providers that have a federal indirect rate assigned. We'd also be asking for a signed certification statement. So the cost report does have a certification statement that needs to be completed by an officer of the provider and then signed. So we ask that that be submitted as well. Any explanations and support for allocations and adjustments and reclassifications of costs. So we'd be looking for documentation and rationale for any type of allocation of costs that are apportioned to CCBHC operations, and then any adjustments that are made on the cost report itself in the reclassification and adjustment columns and worksheets, which we'll talk about in more detail. Support for any DCO costs and visits. So both the DCO costs and visits should be reported on the cost report. And in terms of the cost, those costs flow through to you as a CCBHC provider. If you have a DCO arrangement, we anticipate that as the CCBHC, you would have an agreement with the DCO for the DCO to provide certain services, and then the costs to you of reimbursing the DCO are the costs that the CCBHC should report on the cost report. We'd be looking also for explanations and support for anticipated costs and visits, which we will discuss in more detail. But again, if the CCBHC isn't providing any of the 9 core services currently, or those services weren't reflected in the cost reporting period, you have the opportunity to project what those costs will be under the demonstration and report those costs and visits on the anticipated schedules and lines. So it's important to document and provide any of your estimates and projections and allocations for how that information was calculated and the rationale for why those additional costs are necessary. The cost report also has a personnel schedule that captures personnel, FTEs, and the number of services. And so we'd be looking to see the support that you've used to calculate the number of FTEs for each of the individual practitioners that are listed on the schedule and the number of services provided. And then the last thing would be, last item would be an audited financial statement. Preferably this would be the audited financial statement for the fiscal period of costs that you are reporting on the cost report. But we do understand that in some cases the audit may not have been completed if you've chosen a very recent fiscal period, and so we can discuss alternatives if that occurs, such as the audited financial statement for the immediately preceding year. Okay, so what is included on the cost report? So the first thing that's included on the cost report is direct care costs. This includes direct care costs of both CCBHC and non-CCBHC services to patients. And again, this is an area we'll touch on in some more detail when we get to the trial balance tab. But we want the cost report to tie to your financial documentation to your trial balance in total. So if as an organization you provide services in addition to CCBHC services, the cost report should be completed for all of those services. So there's a section on the cost report for the CCBHC direct services and non-CCBHC direct services. So we're looking for all direct patient care services to be reported in the applicable section on the cost report, regardless of whether they are for CCBHC, the CCBHC program, or for other programs you operate. Next slide. The next cost category would be indirect costs. So these are costs for the overall operation of the facility, including your overhead and administrative costs. And a few examples are shown here, maintenance and utilities, for example. One point of clarity here, I talked earlier about the federal indirect rate. You will still report all of your indirect costs on the cost report, because the costs on the cost report need to tie to your financial documentation, such as your trial balance. But the cost report does have a worksheet to allocate or apportion a piece of the indirect costs to CCBHC. And so we'll talk about that when we get to those schedules. But we're not looking for just the federal indirect portion of indirect costs. We're looking for total indirect costs on the trial balance tab or schedule. The next tab or next slide. In terms of allowable costs, so it's really important as you complete the cost report to be cognizant of allowable and non-allowable costs under federal cost reporting principles. Those of you that are familiar with cost reports have probably seen this publication before, but what we've included here is a reference to CMS publication 15-1, which is a manual for Medicare allowable cost principles that really provides a lot of guidance for completing cost reports for any federal or state program. And what we've shown here is a particular definition related to patient care. So allowable costs at a very high level are costs that are related to patient care. They are common and acceptable in the field, and they're typically your personnel and your administrative costs of operating your facility. Next slide. So here's some examples of allowable costs. In addition to being outlined in the CMS publication that we referenced on the previous slide, we've also included a couple of federal regulations on the left that also contain good guidance. So again, costs that are reasonable and related to patient care. And these regulations also outline some of the acceptable methodologies and treatment for specific expense items. For example, that depreciation expense should be reported on a straight line basis. Related party expense should be limited to the actual costs for the related party, and several other important cost principles noted here. Next slide. So non-allowable costs. So non-allowable costs are not related to patient care, and they're not appropriate or consistent with common practice. And the same CMS publication also contains important guidance about examples of and types of costs that are not related to patient care, and which would be not allowable on the cost report. So what is not an allowable cost in terms of some examples? So a few things here, and again, we'd suggest consulting the CMS publication and these regulations if you're not familiar with them before you begin to complete the cost report, so that you have an understanding of these principles. But some of the examples of non-allowable costs here are bad debt expense, charity expense, donations, political contributions, lobbying expenses, fundraising, and so forth. And then the last cost concept we wanted to touch on quickly again is, if we talked about this already, we'll talk about it a little bit more, but anticipated costs are those that are associated with CCBHC services you're not doing currently or were not present in the fiscal period of costs used to complete the cost report. So a provider might have new or increased staff, new equipment, additional building space. These are the types of considerations you'll want to take into account when developing your estimates and projections of anticipated costs when you look at the cost and anticipated costs and anticipated visit schedules of the cost report. Okay, so in this section of the presentation, we'll begin to walk through the CCBHC cost report. Before we do that, a few introductory slides to this cost report section. So this slide contains the web links to the CMS published cost report and instructions that are available on the Medicaid.gov website. We wanted to note that in addition, that the state will be providing a modified cost report with macros that will allow the user to add cost report lines because the CMS cost report is locked and cannot be edited. So there's no other changes to the functionality. It simply has the ability to add additional lines to report additional types of costs should you wish to do so. And so if you would like to receive that copy of the cost report to use, you can submit a request for that cost report to the CCBHC mailbox at ccbhcquestions@fssa.in.gov. And we talked about this, just went through this on the previous slides, but again, we've noted here some of the important regulatory cost reporting principles that should be followed when you complete the cost report. A few notes here about completing the cost report. So the first thing is the cost report must be prepared using the accrual basis of accounting, not the cash basis. So we're looking for the cost report to be completed on the accrual basis. All requested information in all of the schedules must be provided. So anything on the cost report that is applicable to PPS1, which is all of the schedules except 2 schedules, should be completed in their entirety. And then we ask that all amounts be rounded to the nearest whole dollar except for FTE amounts. So this slide shows a flow chart of the cost report schedules, beginning with the provider information and progressing on through the cost elements and finishing up with the rate and certification. You'll notice there are 2 worksheets that are lined through. They will not be applicable because they relate to PPS2. So those 2 worksheets related to CCPPS2, PPS2 rate, and the monthly visits will not be completed because the state has selected PPS1 as the rate approach. Okay, so now we'll dive into the cost report schedules. And when you start looking at the cost report, the first part is the provider information schedule. And this schedule has 2 parts. Part 1 collects general information about the provider, such as the provider's Medicaid number, national provider ID, NPI, the reporting period of the cost report. And again, we ask for that to be your most recently completed fiscal period, the provider name and address, and a number of other details here. Part 1 of the schedule is completed for single sites and central office information. So it's for the main site that the cost report is completed for. Part 2, it collects the same information as Part 1, but it's completed when providers have multiple sites. So I noted earlier that the cost report will be completed for each CCBHC entity. So if your organization operates multiple CCBHCs, each CCBHC will need to submit a cost report. And if the CCBHC has multiple service locations under the CCBHC, Part 2 is where you will fill out information about each site. And the cost report does allow inserting additional tabs. So if you have more sites than can be accommodated in the standard set of information, you can insert a new worksheet, copy over the Part 2 portion of this worksheet, and fill it out. So the next schedule of the cost report is the trial balance schedule. And before we get to that schedule, I did want to talk a little bit about creating the trial balance crosswalk. So this is a really important step and we think a helpful step for you when completing the cost report accurately. And it's also a necessary item of documentation that we'll be looking for when the cost reports are reviewed. And the need for the crosswalk is because provider accounting systems and the trial balance data that comes out of those systems is very likely not structured in a way that aligns with the cost report lines. And so this outlines the high-level steps to take when you create a crosswalk from your trial balance to map your trial balance costs to the cost report. So the first step is to list out all of your trial balance accounts. So this should include all costs, whether they are applicable to CCBHC, not applicable to CCBHC, allowable or not allowable. So remember, we're looking for all costs. So you'll want to account for all items that tie back to your financial documentation. The second step is then to look at each of those trial balance cost items and assign a cost report line to them, to each one. So you go down through your trial balance and assign a cost report line to each one. Then you would summarize all of those cost items by cost report line, and then you'll have a summarization that can then be entered into the cost report. So this shows an example of what this might look like. So in step 1, you would start with all of your trial balance accounts and amounts. And then in step 2, you would notate next to each of those trial balance lines the cost report line that should be assigned to. So you'll see in this example, the third row of the trial balance is account 6,000 psychiatrist salaries, and that's been assigned to cost report line 1.1 psychiatrist. And so you'll do that down through your entire trial balance. And then once you have each trial balance cost item assigned to a cost report line, you can then summarize all of those up into cost report lines in step 3, and that information is then ready for you to enter into the cost report on each cost report line. So this is the trial balance schedule of the cost report, and this is separated into 3 major sections, and each section has its own subsection. And so before we get into the sections, we'll talk about the columns, because the columns are the same in each section. So first we have the description, and this is where the cost report lines and descriptions are identified. And because the CCBHC cost report, as I mentioned earlier, can't be edited, you will have the option to use, and you can receive upon request, a modified cost report that has the ability for you to add additional lines if you would like. And so if you do that, that very first column is where you would need to provide a description on any of those new lines you add of what costs type you're adding. Okay, and then next to that, starting with the numbered columns, is column 1 for compensation. So this is where you'd report the salaries and benefits of staff. Column 2 is other. So this is everything else that's not compensation, so not related to salaries and benefits of staff. And then column 3 is a formula that adds up those 2 items. So when you add all of that up, if you complete columns 1 and 2, all that adds to column 3. The total at the very bottom of column 3 should tie to your trial balance. Column 4 is for reclassifications. There's also a separate reclassification schedule that we'll talk about in a few slides. So you will have to enter your reclassification in both places. For those of you that aren't familiar with a reclassification, it's basically just a movement of costs from one line to another. So in the example shown here, assume that when the crosswalk was prepared from the trial balance, all of the psychiatrist salaries were assigned to line 1. But actually, some of the psychiatrist salaries relate to performing administrative medical director duties. And so this provider made a reclassification in this fictitious example to move a portion of the psychiatrist salaries out of the psychiatrist line and to an administrative line. Column 5 is then another formula, and it adds up the sum of column 3 and any reclassifications in column 4. Column 6 is for adjustments to costs, and similar to reclassifications, there is a separate schedule for adjustments. So any adjustments will need to be entered here and on the adjustment schedule. And so this is where you would either add costs to a line or remove costs from a line. So for example, to remove non-allowable costs from a line, or maybe to add costs that are allowable to a line for some reason because they weren't on your trial balance. Column 7 is another formula. It adds up columns 5 and 6. And then column 8 is for anticipated costs. Again, like reclassifications and adjustments, there's also another schedule that needs to be completed that needs to match what's in this column. And we'll go over that when we get to that schedule. And then lastly, column 9 is a formula that adds up columns 7 and 8. So those are the columns in the trial balance schedule, and they're the same, like I noted earlier, across all of the sections or parts. So in terms of the parts, part 1 here is where direct CCBHC services are reported. So this is for all costs that are directly related to CCBHC services. And part 1A is for staff costs. And so in part 1A, really all of the costs we should see here are in column 1, compensation, because they're related to staff. Next slide. Okay, so this is the next 2 parts of the trial balance, parts 1B and 1C. Again, the columns are the same. So part 1B is for DCO costs. So any costs that the CCBHC incurs for the DCO's provision of any CCBHC services will be reported in this section, and they'll all be reported in column 2 and after. And then part 1C is for any other direct CCBHC costs that the CCBHC incurs that aren't salaries of the CCBHC personnel and aren't DCO costs. So for example, medical supplies, depreciation for depreciation expense for equipment that is only used for CCBHC services, and any other CCBHC only costs like that go in Part 1C. The second part of the trial balance contains indirect costs, and it is also separated into two parts. Part 2A is site costs, and Part 2B contains administrative costs. And these sections collect cost items like rent and utilities and administrative personnel. And again, you'll see it has all of the same columns as the other parts of the trial balance. And this is also an area where if you are interested in using the macro-enabled cost report, you can add additional lines if you have cost items that aren't captured in these pre-populated lines. And then Part 3 is the last section of the trial balance schedule, and this is where the direct costs for non-CCBHC services are reported. It has two subparts. Part 3A is for direct costs for services that are not CCBHC services, but are covered by Medicaid. So if your organization provides services for Medicaid enrollees outside of the CCBHC program, this would be where those costs would be reported. And then the last section 3B, or last part 3B, is for any other direct costs for non-CCBHC services that are not covered by Medicaid. So maybe there's some services you provide that are covered under another funding source. You would report that in Part 3B. Note here that, I'm sorry, can you go back one slide? Apologies, I have one more quick point to make here. You'll see that column 3 is highlighted in yellow, that amount. We're highlighting that just because we want you, when you fill this out, just pay attention to that amount because it should tie back to the trial balance and the crosswalk in total, because that should represent all of your costs by the time you get down to the bottom of column 3. And then note also column 4, the total there is 0. So this is the reclassification of costs from one line to another. So any reclassification of costs between two lines, one should be a positive and one should be a negative, and that should always net out to 0 at the bottom. Okay, next slide. Okay, so the next schedule is the trial balance reclassification schedule, and this is an informational schedule in terms of the amounts, because the amounts don't flow to the trial balance, they don't flow to the rate, but this is a supporting schedule for the trial. This is a supporting schedule for the reclassifications column, and we ask that you complete this schedule because it can be helpful to you to document all of the reclassifications you may make. And it will also be helpful for our review to be able to understand any reclassifications that you're making on the trial balance schedule. So the schedule is completed by basically providing an explanation of each reclassification and then noting the amounts associated with it. So I'm going to use the psychiatrist example we talked about earlier. This is the reclassification because the psychiatrist performs some duties that are medical director in nature that are really administrative because they pertain to the entire organization's operations and they're not directly with patients. And so the provider in this case has made an estimation of the value of that work by the psychiatrist. And so basically what you do here is you would note the reason for the reclassification in the explanation of entry column, in this case medical director. And then columns 1 through 3 contain the cost report line, description, number, and dollar amount for the increase. And columns 4 to 6 contain the same information, the cost report category, line number, and dollar amount for the decrease. So again, here this reclassification is moving costs into line 40, an administrative line, and out of line 1, psychiatrist. The next schedule is the trial balance adjustment schedule, and this schedule contains the support for any adjustments of trial balance costs. So the main difference between this schedule and the reclassification schedule is it is populated with numerous different types of common adjustments that providers might make. Again, if you're using the macro-enabled cost report, you would have the option of adding more lines if you didn't see an adjustment that matches the type of adjustment you're making. So to go through each column, the first column contains the description of the adjustment that needs to be made. Column 1 contains what's called the basis for the adjustment, and this is just an indicator of what the nature of the adjustment is. So letter A is an adjustment of costs, and you would use B if you're making an adjustment for revenue. And there's a definition associated with those A and B indicators in the cost report instructions, as well as the bottom of the schedule. And then column 2 contains the amount of the adjustment. Column 3 is the expense classification, basically the cost report line description, and column 4 is the cost report line number. So that shows what kind of adjustment you're making, whether it's cost or revenue, what's the dollar amount, and where are you removing that from or adding it to. And again, any adjustments that you document on this schedule should match the adjustments that you're reporting on column 6 of the trial balance schedule. This next slide is the same schedule. It's just part 2 of that schedule. This is just additional lines that contain more common types of adjustments. Again, the macro enabled cost report gives you the ability to add more lines if you need it. And then, like the previous slide, it has an example at the bottom of an adjustment, and this is an example of a bank late fee that's considered not to be an allowable cost. And so this example, the provider is removing that from the trial balance line that it was initially recorded on. Okay, the next schedule is the anticipated cost schedule. As we talked about a couple of times previously on previous slides, this is used to report projected costs of CCBHC services that are not currently being performed or were not represented in the fiscal period of data you're reporting. And again, there could be a lot of reasons for this. There are some services you're not providing, or you anticipate you need to provide more of current services. There's new expenses for equipment or supplies that you'll need to purchase to support the new services. Any of those estimations of cost items that you don't currently have in your financial trial balance or other financial records should go on this schedule. It's populated with the same cost categories as the trial balance schedule. And so you start off with the same types of cost report trial balance lines as you had on the trial balance. It does have the ability to add more lines in the state version of the cost report if you want to add more lines here as well. So much of the anticipated cost items will likely be staff costs for any anticipated new staff that you might need to hire. So we ask that you provide the number of FTEs associated with any new or increased costs related to personnel. So for example, if you're needing to hire an additional psychiatrist, report 1 FTE in column 1 and the associated salary for that anticipated new hire in column 2. Column 3 would be used if you anticipate that there would be a reduction in any anticipated cost amounts. It may not be used, but it's there in the event that it's necessary. And then column 4 is a formula, and it is summing up the amounts in columns 2 and 3. Anticipated cost documentation. So what are we looking for in terms of documentation for these anticipated costs? So the first thing we'd like to see is a description of what the costs are. What are the items you're adding? Are they personnel, supplies, equipment? We also ask that you provide a reasoning for why the costs were not included in the fiscal year period that's being reported on the cost report, and thus they need to be included in anticipated costs. And then lastly, we ask for supporting calculations for any estimates that you utilize to determine the anticipated cost amount. So here what we're looking for is what is the basis for which, what was your methodology and basis that you used to come up with the amounts of the cost? So for example, for salaries for a new hire, did you use your own hiring experience for that position? Did you do some research on wage data in the marketplace? Or did you have some other basis for determining what the compensation would need to be of that person you have not hired yet? Same thing would be true for non-personnel costs. If you needed to purchase some new equipment, what was the rationale for determining how much that would cost? Is it based on your experience for purchasing similar equipment? Did you get a quote from a supplier? Again, we're really interested in seeing, and it really will help you too when you fill out the cost report, in reviewing the rationale and justification for how these amounts are determined. And this slide just has a few examples. We really talked about some of these already, but again, anticipated costs examples here could be wage costs related for new staff of various categories or staff positions, depreciation expense for new equipment, could be new building space for a new building or expanded building, any of those types of cost items. The next schedule on the cost report is the indirect cost allocation schedule. And this schedule determines how much of the provider's indirect costs are attributable to or can be allocated to CCBHC services. So indirect costs are costs that benefit the entire operations. And so if you provide services beyond CCBHC, only a portion of those indirect costs should be allocated to CCBHC services. And so that's what this worksheet is doing. There are 4 methods that are prescribed in the cost report, with the idea that the provider would utilize the first applicable method in order. So the first method is the federal indirect rate, and this doesn't apply to every provider, but if a provider has a federal indirect rate, that's what should be utilized first. And that approved rate is used to determine how much indirect cost should be allocated to CCBHC. So if this applies, the provider would fill out lines 1 through 5 of this schedule with the federal indirect rate information. If you have a federal indirect rate and it's in the process of being reviewed and updated, but a new rate has not been determined, it's probably best to use your current federal indirect rate because the new one has not been established yet. Similarly, if you're applying for but you don't have a federal indirect rate yet, one of the other options, 2 through 4, is probably the best approach. The second option is the 10% minimum rate, sometimes referred to as the 10% de minimis rate. So if you qualify for the 10% rate and you don't have a federal indirect rate, you would use option 2 and enter yes in line 7, and this schedule uses the 10% rate. If you don't have either of those, the third option is to apportion indirect costs using the cost reports functionality, using a percentage calculated based on the trial balance information. So the cost report has a formula in it that when you select yes to question 11, it calculates the percentage of CCBHC direct costs to total direct costs. So the CCBHC portion of direct costs, and then that percentage is then multiplied by total indirect costs to allocate a portion of indirect costs to CCBHC. And then the fourth and final option is labeled other, and this would be used if the provider didn't have a federal indirect rate or did not qualify to use the minimum 10% rate and believes that that third option would not result in an accurate allocation of indirect costs. If those are true, you then have the option to develop your own allocation method, but you must provide a description and a justification of the allocation method that you're proposing to use. And then based on whichever of these options is chosen, line 16 then will show the indirect costs related to CCBHC services that flows to the PPS rate schedule. The next schedule is the allocation description schedule, and this is a blank schedule the provider can use to provide an explanation for how cost allocations were determined. It's really an open schedule that you can use to provide any additional information, helpful clarification that would be helpful for the state and us when we review the data. So it can be used to explain and document methods you used for the trial balance crosswalk, allocations for indirect costs, additional support for any reclassifications or adjustments. So any type of narrative or additional information you'd like to provide, you can use this schedule for that. It isn't required, so if you believe that the necessary support and rationale for all allocations and estimates are included elsewhere in your supporting documentation that you've provided, you don't have to complete it. But keep in mind, we are looking for the best information possible to make our review smoother and to reduce the number of questions we have. So the best information you can provide at the outset is appreciated. Okay, so the next schedule is the daily visit schedule, and this schedule collects the daily visit counts for CCBHC services. So just a reminder again, daily visits are any day in which a CCBHC service is provided to a patient, either by the CCBHC or a DCO. And the daily visit count would be one visit, regardless of whether you provided one discrete service to a patient or you provided multiple services to that patient on one day. The daily visit is one. A couple other things to note about the calculation of the daily visits is that if you provide a CCBHC service to a patient and a non-CCBHC service on the same day, the fact that you did provide one CCBHC service on that day means that that qualifies as a daily visit. You would ignore the non-CCBHC service. If you provide only non-CCBHC services to a patient on a day, that would not count as a daily visit. And then we've talked about this a couple of times already, but again, it's important to note here that as you're filling out, as you're using your information to enumerate daily visits, you're counting up daily visits to all patients, regardless of payer or insurance status. So this isn't limited to Medicaid visits. Okay, so let's go through the lines on this schedule. So line 1 is for CCBHC visits provided by the CCBHC during the cost reporting period based on your historical claims and your patient record data. And you should use that data to, along with the state's encounter code list, to define the CCBHC services that qualify as a daily visit. Line 2 is for any DCO visits, and you use the same method to count the visits, but this would be based on the data that the DCO has, that the DCO will supply to you to enumerate the visits that they provide. Note that if a patient receives a service from a CCBHC and the DCO on the same day, that only counts as one daily visit, not two. And then line 3 is for any anticipated visits for anticipated CCBHC services. So just like you would provide a projection or an estimate of the costs associated with anticipated services, you would need to develop a methodology and an estimate for the number of anticipated daily visits as well. Okay, so this next slide is an example of what a calculation of daily visits might look like. This is not in the cost report. This is an example to kind of illustrate a snapshot of what the data would look like. So we envision you'd start out with some type of claims claims data from your electronic health record system. This example has some baseline claim type information, such as the recipient name, the provider name, the claim number, patient ID, date of service, the procedure code, the payer, and then the dollar amounts, the billed and paid amounts associated with the service. So essentially any record in the claim data that is for a CCBHC service would be counted as a visit, but would only be counted one time per date of service. So if you did this in Microsoft Excel, for example, you could utilize a formula to identify the CCBHC services by procedure code, and then look at the patient and the date of service to count only one visit per patient per day. So in this example, you'll see the first two lines are for the same patient on the same date of service, and they represent two different services on that day, but only one visit is counted for that day. The third and fourth rows are one service provided to each of those patients on each of those days, so each of those lines is counted as an individual visit. And then the last row is an example where there is a service provided by the CCBHC, but then you'll see at the bottom of the sheet, there's a DCO service also provided on that day. And so the total count between those two services is one. So again, we wanted to emphasize that when you're looking at daily services, you want to make sure that it is a unique count of daily visits, whether the patient was at the CCBHC or DCO. And here's just a few points about visit documentation. So SAMHSA requires that CCBHCs maintain health information systems that include electronic health records. And so all services that trigger a visit, daily visit, must be documented in the medical record. And so the CCBHC must use their data and any data that they receive from the DCO for DCO services so that they can bill for demonstration services and then maintain the appropriate documentation of those services. Just a recap of the type of documentation that you need to maintain to support the visit counts. So earlier we talked about a little bit about FTEs. So this is where that comes into play in terms of the staff FTE information. So this is the services provided schedule, and this schedule is also just informational. It doesn't impact the rate, but it is a required schedule in the cost report where providers should report the number of FTEs for each of the practitioner lines and the number of CCBHC services that each practitioner provided. And this is different here in that the data in column 2, you'll note that says services, not visits. So this is important to note that this is capturing the number of individual services that each practitioner performs, including multiple services on the same day. So it needs to be counted differently than you would the daily visits. And then columns 3 and 4 don't require data entry. Column 3 pulls directly from the trial balance, and column 4 is a calculated formula. The next schedule is a comment schedule. This is very similar to the allocation description schedule in that it's just a blank schedule that providers can use to provide any other comments or narrative explanations for anything you'd like to provide additional information about or anything the state should take into consideration when reviewing your cost report information. Okay, we're getting near the end of the cost report, only a couple worksheets left. So this next schedule is the PPS1 rate schedule, and this schedule is where the provider's preliminary rate is calculated. It primarily pulls in information from other schedules of the cost report, including total direct costs of CCBHC services, indirect costs, and it adds those up to total costs on line 3. It then also pulls in total CCBHC daily visits, and the total CCBHC costs are divided by visits to calculate the unadjusted PPS rate in line 6. So line 7 is really the only data entry cell on this schedule, and it's for reporting the inflationary index, the MEI, or Medicare Economic Index. And the cost report instructions indicate that it should be applied from on a midpoint to midpoint basis. So using the midpoint of the cost reporting data to the midpoint of the rate period. So let's assume a fiscal period again of July 1, 22 to June 30, 2023. We can say the midpoint of that year is January 1, 2023. The CCBHC rate effective date, let's just say that's July 1, 2024. And the midpoint of that first year would be January 1, 2025. So for a provider with that cost reporting period, inflation would be calculated from the midpoint date, January 1, 2023, to the midpoint of that first rate year, January 1, 2025. And there's a link at the bottom right of the schedule to the CMS webpage with the data schedule with the MEI factors. You can download that MEI table and calculate the MEI amount here. The state will also be reviewing and independently calculating the MEI factor. And so to assist providers, the state will make available its calculation of the MEI adjustment based on your fiscal period. So if you would like to use the state's calculation when preparing your cost report, please request the MEI amount from the state by submitting an email to the CCBHC mailbox. And then the last line on that worksheet, the last line on that worksheet is line 8, and that's the final rate amount, basically the unadjusted PPS rate in line 6 times the MEI. One thing to note here, so that may not be the final rate. That's the final reported rate on your cost report, and it may not be the final rate for payment because there may be adjustments that we identified during the cost report review, such as adjustments to allowable costs that change that calculated rate. So keep that in mind, that your final rate may be different than the amount that is submitted on the cost report. So the final schedule of the cost report is the certification schedule, and this should be filled out and signed. We're asking it be physically signed, a hard copy, and then scanned to PDF or an image or something that you can then submit electronically when you submit your cost report submission. Here's just a few additional resources. Most of you are probably already familiar with these, but the SAMHSA CCBHC webpage and the the CMS webpage with the cost report and instructions, which again, you have the option of using that cost report from CMS or the state's version that allows for additional lines. The last section of the slide deck is an appendix. It has a number of important terms to know when completing the cost report. A lot of these terms are things we've already discussed today, but we did want to include an appendix as a resource in case there's any definitions you want to look through. We don't plan to go through the appendix today, but you can review that definitions and terms in the appendix along with all of the rest of the information in this presentation by requesting a copy of today's slides through the CCBHC mailbox. And so if you would like to go, if you don't mind going to the very end of the slide deck, we can show the email address again. So ccbhcquestions@fssa.in.gov for any questions you have about today's training. Any other questions for DMHA or OMPP, if you'd like to request the cost report, the state's MEA calculation, any questions or requests, you can use that email address. And that's the end of the cost report walkthrough, and I'll hand it back to Ari for any closing comments.
Thank you so much, Tim. Again, as Tim stated, if there's any questions regarding any piece of this training or requests for any of that information, whether it's the Medicare Economic Index that the state would calculate or any other kind of resource, we would be more than glad to assist. Just please utilize this email here on the slide. And again, if it is a question related to the cost report template process, please put cost report template question or cost report question, something with cost report in the subject line, as that'll help us quickly identify and quickly prepare an answer for that specific question. Just wanted to thank Tim Grant, from Myers and Stauffer for assisting us with this training, and also wanted to introduce our partner from OMPP. There was a little bit of a conflict during the beginning portion of this training, but Kevin, would you like to provide a quick hello and goodbye at the same time?
Yeah, thank you, Ari. I'm sorry. Sorry I had a conflict. I'm Kevin McAndrews, and I'm a reimbursement director for OMPP, and I'm certainly excited about this this project and happy to be a resource and answer any questions you may have as they relate to the reimbursement scope or anything else that I could help assist with. Thanks, Ari.
Thank you so much, Kevin. We're very glad to have our partners at OMPP, as well as our contractors and friends at Myers and Stauffer and ICASO be helping with this initiative. On behalf of DMHA and FSA, thank you so much for watching this training, and please feel free to send questions again to ccbhcquestions@fssa.in.gov. Thank you so much, and have a wonderful day. To stop recording now.